Good afternoon. My name is Joanna, and I will be your conference operator for today. At this time, I would like to welcome everyone to the Vulnerability, Cognitive, Impairment, and Undue Influence, a Recipe for This Treatment conference call. All lines have been placed on mute to prevent any background noise. After the speaker's remarks, there will be a question-and-answer session, and if you would like to ask a question during this time, simply press star, then the number 1 on your telephone keypad. And if you would like to withdraw your question, press the pound key. Thank you. Ms. Molly French, you may now begin your conference.
Thank you, Joanna. Welcome, everyone, to our webinar on Vulnerability, Cognitive Impairment, and Undue Influence, a Recipe for Mistreatment. It's co-sponsored today by the Alzheimer's Association and the National Center on Elder Abuse. I'm Molly French. I'm the Director of Public Health here at the Alzheimer's Association, and I'm joined by my association colleague, John Shane, who's a public policy specialist. So our first step is just to get a better read on who's participating on the call, and so probably on the side of your screen, for most of you, be your right hand, you'll see a poll, and if you just let us know whether your main professional field is public health, healthcare, if you're in aging services, Alzheimer's disease or dementia, or another profession. So while we give you a chance to do that poll, I'm going to do a few housekeeping items before we get started. The first is just to let you know we're recording the webinar, so it'll be available to others, or you can listen to it again at a later time. We have asked our operator to mute all the lines to eliminate background noise. Please, there's a chat function too in that bar on the side of your screen. We'd really encourage and love to get chat comments and questions during the webinar. John will be helping me monitor that, and we will be drawing on that for our 2 Q&A periods. And so the first Q&A period will happen in about 20-30 minutes, about midway through the webinar, and then we'll have one towards the end of the webinar. We really want to make sure that this is a little more interactive as possible. And then next week or soon after, we'll email all the registrants for the webinar, a PDF of the slides, a link to access the recording, and provide you with other links and publications that we feature during the webinar. We do want to acknowledge the Centers for Disease Control and Prevention for the Cooperative Agreement, which enables us to offer this webinar. And again, special thanks to the National Center on Elder Abuse, our co-sponsor. Of course, the opinions expressed during the webinar are solely those of the speakers. Let's take a quick look at those poll results. And we'll wait just a second for that to load up on the screen. It's moving along, so thank you for everyone for participating in the poll. Well, it doesn't look like it's going to pop up on the screen for us, but we see quite a few of you are in the aging services category, and then we have a number of folks who work directly in Alzheimer's disease or other dementias, and then some in public health, healthcare, aging service, and other professions. So thank you again. I'm so pleased to be welcoming our subject matter experts today. Dr. Jeffrey Hall, Ms. Aisha Gurley, and Dr. Bonnie Olsen, and we'll be telling you more about them soon. Today's webinar, the focus is on elder abuse, and it's just really one of the most overlooked public health concerns in the U.S. That there is. And it's particularly a problem for people with Alzheimer's disease or other dementias, or even other forms of cognitive impairment. They're just particularly vulnerable to abuse and neglect and exploitation. And we hope that you'll get some new insights from today's webinar, as well as understand how you can begin acting on this issue of elder abuse, especially for people with cognitive impairment, particularly by raising awareness, promoting prevention, and collecting and using data about the problem. Because we have so much ground to cover today, we've decided we will be conducting a future webinar on financial exploitation, which is a growing type of elder abuse. So that will be coming in the future. So I wanted to draw your attention to our format. Again, I'll speak real briefly, then it'll be Dr. Hall. We'll pause for your questions and comments after about some information about some new uniform definitions. Then Dr. Olsen and Dr. Hall and Aisha, Ms. Gurley and I will be talking. We'll wrap up the presentation part with some options for the public health community's response to the problem of elder abuse, and then our second discussion period will start. All right, well, first some quick background about the Healthy Brain Initiative, which is why we're here today. The impact of Alzheimer's disease on communities across the U.S. is considerable, it's quite complex, and really needs a multifaceted response and the involvement of partners from all sectors of our communities, and including the government and private sector. And so for this reason, in 2005, the Centers for Disease Control and Prevention and the Alzheimer's Association established a Healthy Brain Initiative. And so fast forward 11 years, and today with many other public health partners, the Healthy Brain Initiative is going strong, providing the impetus to encourage and foster and support public health action on promoting cognitive health, addressing the needs of people with Alzheimer's disease and other dementias, and addressing caregiving. One way we've operationalized the Healthy Brain Initiative is to release a set of roadmaps. The second roadmap and current one was released in 2013 and focuses specifically on what state and local public health agencies and their partners can do in terms of promoting cognitive functioning, addressing cognitive impairment, and ensuring the needs of caregivers and other professionals are supported. One way that, with the roadmap has 35 actions that the public health community can do over the next 5 years. So it's meant to be very practical. It's a wonderful resource. If you don't have it, I encourage you to get it, and I'll tell you where to get it at the end of the webinar. But the actions really align with some of the essential services of public health in terms of monitoring and evaluating, educate and empower, developing policies and mobilizing partnerships, and really building up workforce competencies that are needed. And today's webinar helps address 2 of those roadmap action items. One is conducting and collecting surveillance data to help mount an effective response, and then the other is promoting awareness of abuse and exploitation and supporting efforts to prevent elder abuse, particularly for persons with dementia. So on the subject of surveillance, in 2013, 19 states and also Puerto Rico used an optional module, which is a set of questions in the behavioral risk factor surveillance system. And through this annual health survey in 2013, they collected additional information about the extent to which people were reporting some type of cognitive decline. The data from the 19 states indicate that 1 in 10 middle-aged and older adults are reporting subjective cognitive decline, or what you might think of as increasing problems with memory, loss, or confusion. Nearly 2/5, or 41% of the people who reported subjective cognitive declines indicated that their memory loss or confusion was significant enough it was starting to cause problems in their daily lives. Specifically, 30% said they were having trouble with everyday household chores like cooking, cleaning, paying bills, and taking their medications. A third of those people said that their memory loss and confusion was was interfering with their ability to work, volunteer, do other social activities in their communities. So these these people who are having, beginning to have memory problems, confusion, other cognitive difficulties that are starting to interfere with their daily lives, these are the ones who are beginning to be particularly vulnerable to abuse and exploitation. And then as cognitive decline progresses, and if it does, cognitive decline is a predictor of future dementia. And to the extent of Alzheimer's disease is the leading cause of dementia. And this chart shows that we can expect that elder abuse of people with dementia and Alzheimer's disease is likely to be an increasing issue in many communities just because the number of people living with the disease is projected to triple. So in 2013, about 5 million Americans were living with the disease, with Alzheimer's disease and other dementias, and that's supposed to rise to, we expect that to rise to about 14 million in 2050. And just because of the degenerative nature of the Alzheimer's disease as a degenerative brain disorder, it eventually affects people's memory, their cognitive skills, their ability, and particularly their ability to care for themselves. And this is why it's one of the most costly chronic conditions in the U.S. To society. And so as the number of people with Alzheimer's disease and other dementias increases as the baby boomer generation gets older, we're going to expect to see the costs also rise. And this is why it's really vital for the public health sector to act on Alzheimer's disease and other dementias from multiple fronts, and including the issue of elder abuse. Now that you have some background about the Healthy Brain Initiative and Alzheimer's disease, I want to introduce Dr. Jeffrey Hall. He's a lead behavioral scientist in the Division of Violence Prevention at the Centers for Disease Control and Prevention. His subject matter expertise is in youth violence prevention and elder abuse prevention. As a medical sociologist by training, Dr. Hall holds degrees in epidemiology, general sociology, and psychology, all from the University of Alabama at Birmingham. Dr. Hall, will you tell us about elder abuse and why it's a public health issue and more about surveillance?
I'll be glad to. Good afternoon, everyone. I'm going to proceed with my presentation at this point. CDC focuses on preventing violence throughout the lifespan, from early childhood into older adulthood, as well as before it occurs. Why is it that we care about elder abuse, and why should we all care about elder abuse? First, elder abuse is a source of significant illness, injury, and distress, as well as a source of disability. Second, illnesses, injuries, and chronic conditions may be exacerbated by elder abuse if they co-occur. Third, elder abuse may disrupt health promotion, self-care, and disease management activities. Most unfortunately, persons who experience elder abuse may not live as long as those who do not. We hope to be fully successful in improving and preserving the health and quality of life of all older adults. To do this, we must address elder abuse as well as other health threats. We care about brain health as it relates to elder abuse because sources of cognitive impairment that become more common with age may increase victimization risk, first by reducing decision-making, self-protection, or disclosure abilities. Second, may make elder abuse detection, investigation, measurement, or substantiation challenging. And thirdly, can severely complicate efforts to prevent and stop elder abuse. I was asked to talk briefly about CDC's most recent contribution to strengthening public health surveillance on elder abuse. Our elder abuse surveillance uniform definitions and recommended core data elements publication was released earlier this year and is now available for public access. Elder abuse can be prevented or halted. However, preventing elder abuse at a population level requires data that will support effective action. The showcase quote motivates us. We seek data that will effectively and powerfully tell the stories of those who have experienced elder abuse, and data that will allow us to definitively tell what works in elder abuse prevention. Such data can tell us how to allot our attention, relationships, and resources to achieve elder abuse prevention and intervention objectives. The definitions and data elements are not CDC's achievement, but those of many persons who've dedicated their careers to eradicating elder abuse. Numerous experts work with us to suggest content that could start conversations to unify the many sectors sharing the charge to protect our society's older adults. The creation of uniform definitions and recommended core data elements is just a first step in a larger process addressing causes of gaps in what we know about elder abuse. And at this particular point, I would like to acknowledge and thank the persons that worked with us to pull off this particular task. Now, in terms of some of those discrepancies and gaps that I just mentioned, these include long-standing differences in the conceptual and operational definitions that exist, as well as differences in the data elements used to identify as well as document elder abuse. Okay. I'm sorry, I'm experiencing a little bit of lag here. These differences make it impossible to compare the size and the characteristics of the problem locally and across states. Moreover, we can't monitor trends and patterns in the occurrence and impact of elder abuse nationally because each operational level essentially speaks a different language. Yes, others have created definitions before. We know that there are doubts about whether useful definitions and data elements can be developed, and that some will be concerned about the possible loss of operational flexibility in data collection that accompanies use of standardized definitions. Finally, we're also aware that policies limit options for how data can be collected and reported. But we forged ahead believing that much can be gained from finding common ground between sectors and from formally identifying what each sector collects and values uniquely in service to older adults. The definitions were developed in 3 comprehensive steps summarized on the current slide. First, the expert panel studied the pros and cons of existing elder abuse definitions, drafted a first round of proposed definitions and data elements, and distinguished core data elements from supplementary data elements that could be collected, resources permitting. Next, CDC integrated the panel's recommendations, devised definitions for terms in the definitions requiring further clarification, and finalized descriptions for the data elements. The manuscript developed in stage 2 was returned to the expert panel for a final review and then prepped for peer review. The peer review process entailed critiques by 18 reviewers not affiliated with the initial panel. Reviewer critiques were integrated into a document subsequently cleared and released by the CDC. We would be remiss at this point if we didn't also acknowledge and thank our peer reviewers who kept us on task and helped us to move forward with this effort. So what is it that we created? What is it that we developed? Proposed uniform definitions were developed for elder abuse, involved parties, and for physical abuse, for sexual abuse, psychological abuse, and neglect, and lastly, for financial abuse or exploitation, as well as for associated definition components that could cause confusion or disagreement. This includes concepts of relevance for our focus with this webinar, such as capacity and competency. Here is an example of content used to help define elder abuse. The definition is presented first and then followed by sub-definitions and contextual information for terms such as intentional or intentionality and concepts such as the expectation of trust. As you can see, with the content provided for physical abuse, the same format is used for each elder abuse subtype. And I won't go into each specific domain of elder abuse that we actually gave attention to, but you can take a look at that content in more detail for yourself if you go to our website at the CDC and access the definitions that are publicly available. The recommended core data elements include categories corresponding to the 5 types of elder abuse, as well as supporting categories such as identifying information, demographics for older adults as well as for abuse perpetrators, and situational data elements for older adults and abuse perpetrators, respectively. We've almost reached the point for Q&A in terms of the webinar, but before that point begins, I have 2 final slides that I'd like to briefly expose you to. Please note that the discussed content is intended for voluntary use in gathering data on elder abuse within a public health surveillance framework, and is not a set of mandates, but is intended instead to initiate a dialogue to improve consistency of elder abuse measurement and surveillance. Furthermore, most terms included in the content that has been released are only comprehensively defined and require further work to be used professionally as well as practically. Lastly, structured decision-making systems and standards may be needed to ensure accurate use and consistent use of the definitions and of the provided data elements. So, what are some possible next steps for this work? First, pilot testing and evaluation of the uniform definitions and recommended core data elements is required to assess and improve their usefulness. In addition, CDC is working to release elder abuse surveillance supplementary data elements. These will provide more extensive opportunities for expanded surveillance, for studies of modifiable risk and protective factors, and for research to inform practice. A final possible next step could involve formal examination of other related phenomena in a manner similar to that done with the current project. For example, self-neglect is a logical and important next focus for definitional attention. So at this point, I'll close this part of my presentation and open the floor up for questions.
Thank you so much, Dr. Hall. As the new surveillance guidance gets piloted and starts to be used, I know that it's a really important contribution to the field, because then we'll have data that will help us to better understand the scope of elder abuse, who's most at risk, and then it's, as you pointed out early in your presentation, it's really critical to mounting an effective effort to prevent more cases. Joanna, would you please open up our lines for our queue for our first period of questions and answers? And if you are participating on the webinar and you prefer, we'll also be taking questions from the chat feature.
Yes, at this time, if you'd like to ask a question, please press star, then the number 1 on your telephone keypad. Again, that's star 1 to ask a question. And your first question comes from the line of Samantha Opakin.
All right. Hi, Samantha. Samantha, we're not able to hear you.
Samantha, your line is open. Your next question is from Deborah Burton.
Hi, I'm calling in from Rhode Island, and I noticed that the BRFSS was not administered in several of the states with the highest elderly population, such as Maine, Florida, West Virginia, Pennsylvania, Montana. And do you think that might have a significant influence on skewing your data?
Well, the data that, this is Molly French, the data that we provide on the BRFSS is just it is only for, it's an aggregation of those 19 states. And so the data, do vary a little bit depending on which grouping of states use the module. In 2015-2016, with the BRFSS, the Behavioral Risk Factor Surveillance System, we will be able to get more at national data.
Yes, and I think you find a significant increase when you target those states with the BRFS of more people self-identifying the subjective cognitive decline.
Yes, it's a very good point, and we're dependent on the state public health agencies to accept the optional module. So we work in partnership with the BRFSS. Thank you very much. I'm going to switch now to one of our chat questions. So one of the questions, Dr. Hall, is what is the connection, if any, between the CDC's definitions and data elements and the recently released definitions and data elements, the NAMRS, from the Federal Administration of Community Living? And maybe, Dr. Hall, you could also provide the acronym or what NAMRS stands for. Thank you.
Okay, yes, thank you for that question. That is a good question. The NAMRS system, that stands for the National Adult Mistreatment Reporting System. That is a system that was co-developed by the Administration for Community Living as well as ASPE in conjunction with a number of other federal agencies serving in a advisory capacity with the development and the stand-up of that system. The NAMRS work is something that CDC has been involved with from the very beginning. It is kind of funny, actually, how integrated into that work we are. Stephanie Whittier Eliason, who is the major contact for that system at ACL, along with myself and Nick Fox, back, I believe, around about 2007, 2008 or so, started talking about a concept that could involve a ground-up process of incrementally talking to different sectors, starting with APS, about their data needs, having conversations to get a better idea as to what would be important to capture, and to also begin a bit of brainstorming about how we could get past some of the technological and logistic complications that exist in terms of compiling national data together for systems such as those stood up within APS. So the definitions that I've just briefly touched on, they informed part of what was put out in terms of the list for possible data elements included within the NAMRS system. The definitions themselves were shared in an early format with the group that came up with the format and the plan for that system, and so we were a part of that effort at the very basic level.
Oh, thank you, Dr. Hall. One more chat question, and then we'll, just so we make sure we have sufficient time for our next set of presentations. One question that came in to us from the chat feature is, how will the data that is collected using the uniform definitions, how will that data be compiled, if at all?
Well, as I mentioned with the presentation, this was a baby step, and it's important to have a growth mindset in terms of how you think about these things, because we acknowledge that this is not a Rosetta Stone, this is not a Bible, it's not a Torah, it is not any of those major seminal documents that you tend to think about as having the potential to be immediately a translational thing for everyone. We look at it as a first step because we realize that there are major issues and challenges that have to really be thought about systematically and carefully so that the different sectors that will use the definitions and the data elements are considered in terms of the demands that they have where their work is concerned. We don't wish to try to impose something on people that's not going to effectively work within the practical settings that they have to live within every day. And we need to do some evaluation work, as I mentioned, to get a better sense of what it would take to reach that common space that I mentioned, where at least at a core level, you have different sectors using the same definitions and the same data elements that would allow us to develop a stronger picture of the experiences of elder abuse by older adults here in the U.S. So in terms of summarizing what I just said, this is just the first step. We're not at a point where we're ready to move into a system that it would do justice in terms of being able to provide national estimates, but we are at a point where we're trying to work at the ground level to figure out what it would take to be able to have data collection with these data elements and with these definitions happening across different sectors.
Thank you. Data is always much more complicated than you think it is, and so appreciate that nuanced discussion. Thank you, Dr. Hall. We're going to go ahead and close this first Q&A period. We will have a second one towards the end of this webinar. Just to answer a quick common question asked by many in the chat function, we will next week be sending out the PDF of the PowerPoint as well as a link for the recording of this webinar. So we appreciate your interest in that. We're fortunate today to have Ms. Aisha Gurley with us. Ms. Gurley serves as an aging specialist for the Administration for Community Living in the Office of Elder Justice and Adult Protective Services. She joined the agency in 2010, and she's responsible for the Administration for Community Living's Elder Abuse Prevention Program. Ms. Gurley, would you tell us a little bit about the Administration for Community Living's work and particularly what it supports through the National Center on Elder Abuse?
Hi, I'm Aisha Gurley, and I'm an aging specialist with ACL. We've been working with NCA for approximately, probably about 8 to 9 years. Initially, NCA was designed out of a demonstration grant in 1992 as a result of the amendments of the Older Americans Act. And so the Resource Center has been dedicated to prevent elder abuse, neglect, and exploitation by improving response and elder mistreatment. Myself and the staff members at NCA have been working on an array of ideas and an array of things, such as the World Elder Abuse Awareness Day, which is June 15th. So if you haven't done anything, please find something to do with your state and your organization to identify ways to prevent elder abuse. NCA has also served as one of our expertise in providing technical assistance and training to states and community-based organizations. They also provide an array of information to all sorts of professionals, as well as persons in various organizations and public worldwide. If you care to find out more about NCA, you're welcome to visit their website, which is www.nca.aoa.gov. And also you can visit ACL's website, which is www.acl.hhs.gov for additional information on NCA and ACL and the things that we're doing as it relates to preventing elder abuse and mistreatment against elders and seniors. As we move forward in the agenda, I would like to introduce Dr. Bonnie Olsen. She will also share with you on susceptibility of people with dementia and of elder abuse, but I'll give you a brief background on Dr. Olsen and some things that she's working on and things that she's done. She's a clinical psychologist with extensive experience as a geropsychologist. She serves on the faculty of the Keck School of Medicine at the University of Southern California and is a part of a patient-centered primary care collaborative team. As the vice chair of the academic affairs in the Department of Family Medicine at USC, Dr. Olsen is involved in research on elder abuse, education, and prevention in the capacity that contributes to National Center on Elder Abuse. Without further ado, Dr. Bonnie Olsen.
Thank you so much, Aisha. It's a pleasure to be here this morning, or this afternoon, as the case may be, depending on where you are. I'm going to be talking a little bit about dementia and how that condition creates the vulnerability for mistreatment to occur. So to provide just a little bit of basic background, I'm just going to review quickly what dementia is and some of the components of that. So as I hope most of us on the line know, dementia is a degenerative condition, meaning that it will get worse over time, that it includes an impairment in at least 2 cognitive domains. Most typically, at least one of those is memory, but not always. There also is an impairment in functional capacity, which would suggest that it's a change from where the individual was able to function in the past, and that these changes are not due to reversible causes. So it's something that is a condition that the individual who's suffering from it isn't able to do anything to really correct that. As a diagnosis, as a medical diagnosis, it really doesn't tell us very much about the individual's capacity to do things or to make decisions. And that's where sort of the interface between dementia and elder abuse often occurs. There are many kinds of dementia, as mentioned earlier by Molly. On this slide, I just put in the most common forms that we see every day in clinical practice, which would include Alzheimer's disease, which is by far the most common, but also frontotemporal dementia, Lewy body dementia, and vascular dementia. In addition, there are dozens of other forms that are less common. And here I wanted to just depict that even within the same diagnostic category, there's a great deal of variance depending on the stage of the disease that the individual is in. So we expect over time that it gets worse, and it has a very different presentation, and as such, it creates different kinds of vulnerability depending on where an individual is in the course of the disease. Here I wanted to illustrate that the individuals who suffer from dementia often have other, what we would consider comorbid conditions that further complicate both the treatment and management of the disease, and also complicate and create greater vulnerability to mistreatment in varieties of ways. So some of these things occur as part and parcel of the disorder, of the dementia itself. So they occur more commonly. So depression and delirium occurs very commonly in the course of dementia, but many other things happen just coincidentally. Things like diabetes or congestive heart failure, pain syndromes, or comorbid substance abuse. And it's important to keep these in mind when we're working with individuals who may be mistreated, so we better understand the complexity of what they're struggling with. Here I'm wanting to talk about the particular types of cognitive impairments that I believe create the greatest degree of vulnerability. Certainly, short-term memory impairment is the single most prominent symptom that creates the vulnerability. And I think that's kind of self-explanatory. When an individual has poor complex attention, what that generally results in is an inability to complete multi-step tasks, things like preparing meals or balancing checkbooks or paying bills. Those kinds of tasks then create dependency on someone else to do those tasks for one, and through that dependency then can come the vulnerability to mistreatment. Patients with dementia have impaired reasoning and problem solving. Again, that will create dependency on someone else to do it for them, or result in them doing a poor job at it, so that they may make decisions or choose to solve a problem in a way that puts them in precarious positions or creates their vulnerability to being mistreated. The lack of insight into their own limitations often means that patients who suffer from dementia are not aware that they need certain types of assistance and help in daily life. And that sort of reluctance to accept those kinds of assistance then creates vulnerability and the opportunity for predators to sometimes take advantage of an individual. As Dr. Hall was talking about before, the very difficult process of collecting data regarding elder abuse and dementia My experience with this comes through efforts to do research in that domain. And so I have a real personal experience of how hard this can be to get clear ideas about how this presents. The population is very difficult to reach and to engage in research or data collection. The victims may deny or accept the abuse as a normal part of life and not see it as something out of the ordinary. Patients with dementia have questionable capacity to consent to participate in research, so that we're often having to have someone else consent on their behalf. And then often the validity of their responses is very questionable. Often the perpetrator of the mistreatment is the caregiver, not always, but often, and this creates also huge complexities in trying to collect reasonable data that we can rely on. And then lastly, the victim often defends the perpetrator and denies that the abuse even occurred. So for all these reasons, we have a very hard time coming up with solid numbers regarding the prevalence and incidence of elder abuse in the dementia population. In a more general format, we do know that elder abuse in general occurs at alarming rates. Nearly 6 million individuals were reported in 2010. And we believe, based on the data that we have available, that only 1 in 23 cases are actually reported. We know that average age is 78 and that female victims are more common. This last statistic indicates that people with dementia are believed to be mistreated at about a 50% rate, which is extremely alarming. So the issue of capacity relates to mistreatment with dementia in very clear ways. And I'm having trouble. There we go. And this is to sort of illustrate the varieties of ways that the capacity plays into this whole scenario. So an individual may have the capacity to formulate a plan, let's say to take some equity out of their home and give it to an individual that they care about. But they may not remember the plan that they've devised long enough to enact on it. They may be able to perform a task like, as I mentioned earlier, balance a checkbook or manage their own medication or complete estate planning documents, but they may not understand or appreciate the implications of the decisions that they're making or that the task that they're engaging in. They may be able to express a choice or express consent to participate in some activity or to complete some legal documents, but again, they may not appreciate what the meaning to themselves may be. There's a difference between being able to make a decision, having that capacity to understand and appreciate what the decision is, but they may not have the capacity to complete complex tasks and take care of themselves in complex everyday activities. So there's a variety of ways that individuals become incapacitated as a result of the dementia. Okay, and I'm not able to advance the slide.
John.
There we go. Now we're on to the next slide. Sometimes it's useful, I think, to use some cases to help us to understand what this looks like in a sort of more pragmatic manner. So what I'm showing here is a case of an individual that I evaluated who was an 82-year-old Korean woman who was married, and her husband had been arguably sort of a bully in the family for many years, with several adult daughters who were also unable to stand up to him. He would put her in a recliner chair and leave her there for many hours during the day when he went off to take care of his own activities. She was found to have had multiple falls, bed sores, and was dehydrated, and clearly was provided grossly inadequate care. and she had been an individual who suffered from dementia related to Parkinson's disease. And this was a case I was involved in that was successfully prosecuted. The next case is an individual, Mr. Jones. Obviously, that's not his true name, but an individual that I also was involved in his case, a 78-year-old man who had been widowed and then suffered a stroke and had mild vascular dementia with hemiparesis. When he was discharged from his care facility back to his own home, the family determined that their adult grandson, who was unemployed, would be the ideal caregiver for him. And on the surface, that looked like a very viable plan. However, this grandson then proceeded to mistreat him both physically and emotionally in an effort to gain control over his finances. And he would, in an effort to have him kind of out of the house so that the grandson could sort through financial documents and so forth, he would drive the individual several miles from his home, leave him there, and his rehab was to find his way back home. Of course, this was unreasonable and led to some serious harm to the patient. And again, it was a case that was ultimately prosecuted. The next case is Mrs. Perez, who is an 68-year-old widow who was living alone in her own home. She had been diagnosed with mild Alzheimer's disease and was doing quite well on her own despite having some mild symptoms. One of the symptoms she had was some subtle suspiciousness and bordering on paranoia. And to sort of manage her fears about what the neighbors might be doing, she decided to install a security system on her home. The contractor that she hired suspected that her suspicions were greater than one would expect and sort of preyed upon that symptom. So in the end, he charged her $125,000 for a system that really was worth only $24,000. Again, this was a case that was prosecuted, and Mrs. Perez was able to get her money back. So that was a good outcome in the end. This last case is to illustrate how professionals might victimize an individual who's suffering from dementia. So Mrs. Pearl is an 88-year-old woman who was living alone in her own home, and she had a moderate case of Alzheimer's disease and was struggling to take care of her own needs. Someone had referred her to a local attorney who came in to help her manage her estate planning documents, identified that she was vulnerable and preyed upon that, so that he wrote documents that effectively made himself the beneficiary of her estate, and then removed her from her home and placed her in a care facility where then she lived out the rest of her life. So that just is to illustrate one of the ways that an individual with dementia can be mistreated. I'm going to switch over and talk a little bit about prevention and more of a public health perspective on how dementia and elder abuse interact. Our thought is that education is the strongest way to get to prevention. And so our efforts are to engage family caregivers in education and help them to understand the risks that they might become abusive over time. This occurs when the caregiver becomes overwhelmed, and we know that there can be, not always, but there are times when that leads to this sort of slippery slope to mistreatment. And clearly, educating caregivers about these risks can help them to find alternative ways to manage the burden of being a caregiver so that then they're able to provide adequate care and protection to their loved ones. The next area would be to inform and educate both family and more formal care providers, whether those are healthcare providers or hired caregivers. Help them understand where the vulnerability comes from through this cognitive changes to help protect the assets as well as the individual's person from mistreatment, and to be really active participants in observing, reporting, and protecting individuals from mistreatment. And lastly, then, in a broader sense, to help the public understand that ageism is a concept that often leads to people being mistreated, that keeping individuals over the age of 65 as a separate category and not part of the mainstream of our communities creates vulnerability. We want the public to become involved and to report suspicions when they see them. So at this point, I'm going to hand the comments back to Dr. Hall, who will be talking a little bit about further public health issues. There are some resources through the National Center on Elder Abuse that we have available to participants, and I believe that these will be made available after the presentation with some web links and so forth. We have a fact sheet about abuse in the context of dementia, and then we have 2 educational materials that we've developed through the funding through the Archstone Foundation, which are educational materials for caregivers, one in English and one in Spanish for caregivers to learn more about how to protect their loved ones. So, Dr. Hall, would you like to continue from here?
Sure.
We'll advance your slides, Dr. Hall.
Okay, that's fine. So just to do a little bit of wraparound, we just had a few more final thoughts with respect to the content that we just covered. Going back to what I mentioned where the definitions and data elements were concerned, there's 2 additional points I'd like to make. A lot of times people will say, okay, so what is the point of having focused on defining things? Well, I'm a sociologist by training, and one of the concepts that stuck with me from my first sociology class is this thing called the Thomas Theorem. And what that theorem proposes is that what we define as real is real in its consequences. You can also sort of say that what we don't define is also real in its consequences. So we recognize that when we talk about definitions, we're really getting into an area where this is a social construction process. So the content that we developed in conjunction with our experts and with the guidance of the external review panel really hopefully will provide major assistance to the field by further positioning the field to more cohesively describe the core dimensions or facets or characteristics of elder abuse. We hope that some of what we were able to struggle with in that area will help to make some steps forward in that regard. We also hope that in some way we add content and we add additional information that will improve the classification of the behaviors that indicate elder abuse. Now, we know that there's still a lot of work to be done. So, for example, if you take a look at the little conceptual figure that I have there on the slide, you'll notice that abduction and abandonment are not directly included under elder abuse in terms of what could possibly be there, and that's because there were several constructs that we dealt with in the definitional effort that we couldn't quite get a good frame around just yet. They could either be classified, for example, possibly as a subtype of one of the other forms of elder abuse, or they might actually be considered to exist independently and need to have attention in their own right. So in this respect, we hope to be able to offer at least some movement forward in thinking about how it is that we're supposed to deal with and measure different types of behaviors, different types of phenomena. And in that same vein, I mentioned self-neglect. We didn't include self-neglect under elder abuse, which is something that's done by a number of other organizations, a number of other entities. And one of the reasons that we chose not to have that be the case for us is that we follow a model that's consistent with the World Health Organization that deals with violence and similar phenomena based on intentionality. So elder abuse essentially is considered to be an intentional act, whereas self-neglect is also intentional, but instead of it being directed towards an older adult by someone else, it is actually more along the lines of self-directed behavior. So in this respect, we pulled that particular related phenomenon out and said that it, along with resident-to-resident abuse, deserves to have additional independent focus. So in terms of what it is that we offer with this type of effort, we really hope that the work itself would provide some contributions that would help to strengthen the way that we examine, investigate, and respond to elder abuse, as well as how it is that we go about getting information to help us tell the best and strongest story about those individuals who have suffered these unfortunate experiences. Next slide, please. And in terms of the data side of this, data is just a tool, really. We would be remiss if we didn't say that data isn't just something to consider abstract. We think about data as just the quantitative manifestation of a person's life. So we take surveillance very seriously because it gives us the fortune and the opportunity to be able to represent the experiences of millions and millions of people who unfortunately have been the victims of elder abuse. What we hope to be able to do in trying to get into a common space with data collection and data elements is to allow more conversation and more clear interaction and coordinated use with respect to the stores of information that all these different sectors accumulate when they essentially serve the same population. And we hope by taking, as I said before, what we consider to be a small but important step, that we can create some momentum that will, again, incrementally move the field forward with respect to being able to use data to make a giant leap forward on behalf of older adults.
Thank you, Dr. Hall. And I wanted to wrap up this public health implications section with, just recalling, going back to the Healthy Brain Initiative roadmap for public health professionals and partners. And the our public health roadmap for the Healthy Brain Initiative, calls upon the public health community and its partners to do 3 essential actions. So one is, the ongoing need to collect and use surveillance data, especially using the new uniform guidelines that CDC has proposed on elder abuse, but then also more generally on subjective cognitive decline. And then second, given the increasing number of baby boomers who are expected to have developed Alzheimer's disease and other dementias, it's really important that public health try to start working now to build awareness across the community and with other partners about abuse and exploitation. And if you're in adult protective services, AAA, or nonprofit or government agency providing senior services, and those to the disability community, we really need you to get out there and start talking to your public health colleagues about the problem of abuse and exploitation. And then thirdly, the public health community has the opportunity to support the prevention of elder abuse, especially for people with dementia. And both the Centers for Disease Control and Prevention and the National Center on Elder Abuse have information to help public health and others in the elder abuse, adult protective services, AAA, and others in the aging services community to increase awareness and action on these topics. In fact, there is an elder justice roadmap that can be helpful to all parties who have a stake in this issue. So just to direct your attention, we'll go ahead. I know it's 2 o'clock now, and we appreciate everyone staying with us. We do want to fit in a couple more questions and answers. Joanna, if you would go ahead and open up the lines. And while you open up the lines for callers, I'm going to do one of the questions from the chat area. Joanna? Joanna, would you please give the participants some instructions about how to queue up? Well, while we wait for Joanna, one of the questions, Dr. Olsen, that we received through the chat function is, what's the difference between the decision-making capacity and executive functioning?
Okay, it's kind of hard and difficult to describe the difference, but sometimes individuals with dementia are able to express a choice. For instance, something like, I would like to give my house to my housekeeper or my caregiver, or I want to take the equity out of my home and get a reverse mortgage, some version of that. They have the capacity to make a decision, express it, and perhaps even understand the implications of it. But they may not have the capacity to do a functional task that is ongoing and has multiple steps to it, such as be able to prepare their own meals or manage their own medications. It creates different kinds of vulnerability when there's decision-making incapacity versus executive or sort of doing things incapacity. And I think as sort of a healthcare provider, when we're evaluating patients, we need to be cognizant of both sides of that equation so that we don't just attend to one and not the other. When an individual isn't able to do everyday complex tasks like those independently, then they're dependent on someone else to do it for them. Those arrangements need to be put in place if possible. And then that creates a different kind of vulnerability to mistreatment.
Thank you. Both Dr. Olsen and Dr. Hall, we've gotten a question about, are there some existing training? Both of you have mentioned, but particularly Dr. Olsen, you mentioned the need for educating professionals as well as older adults and caregivers and the general public. But in terms of professional development, are there best practice trainings or educational trainings that are readily available on the topics we discussed today?
This is Dr. Olsen, and I can give a brief answer to that. Through the National Center on Elder Abuse, we have a website called we call it TRIA, Training Resources in Elder Abuse. And on that website, we have a listing of all kinds of educational materials that have been reviewed and vetted for their appropriateness, if you will. And they're for all different constituents. So there's some are for family caregivers, some are for professionals working in various roles within the healthcare community or in care facilities or varieties of different ways. But it's a website that is really useful to go and find training and educational materials. We will make that link available so that participants on the call, I'll make sure that that link is provided along with the other ones from National Center so that you can look at that and find the training that was going to be most useful for you.
Thank you, Dr. Olsen. And Dr. Hall, did you have any other resources you'd suggest that would be helpful to professionals who work with older adults?
I think that the ones that were just suggested are excellent ones. There are a variety of different places that you can go to from a variety of different federal and non-federal entities. We, for example, have links to a variety of different groups who are very much engaged in this effort and committed to serving older adults who have different sets of resources that might prove useful to people that are, very much interested in this topic and want to do something about it. So if you'd like to access that information, you could go to our website, www.cdc.gov/injury, and you should be able to select Division of Violence Prevention, and from there, go to the Elder Abuse topic section, and you'll be able to access a plethora of information that will be helpful.
Terrific. Thank you, Dr. Hall. we're going to go ahead and we really appreciate everyone who joined us today for the webinar. I feel like we just touched a few, not even the tip of the proverbial iceberg. There's a lot of depth and complexity to this issue, but we really appreciate everyone's participation to learn more about elder abuse, particularly as it relates to people with cognitive impairment who are particularly vulnerable. And so I just kind of wanted to provide you with a few key websites for more information, what places that you can go to get additional information and resources, learn more. And so there they are, and we'll be sending out the links as well as some publications and a link to access the recording of this webinar next week sometime. So I do want to say a special thank you to Dr. Olsen, Dr. Hall, and Ms. Gurley for helping us learn about elder abuse, and particularly the vulnerability of people with cognitive impairment and what the public health community and their partners can be doing. Again, thank you. And Joanna, if you go ahead and close the conference for us.